All right, let's carry on. We're going to be recording today. So let's talk about fractures. Basically, a fracture is any disruption or a break in the structural integrity of a bone. Now, you don't have to, as far as having a fracture, you do not have to have something as you see here that is quite obvious of what on this x-ray where even a blind person could see and tell that this was a fracture. But basically, what we're looking at here is anything that causes a defect, primarily from trauma, either directly from trauma or potentially from pathology, not pathophysiology, but pathology of the bone itself that can lead into a problem. Now, here's the thing with fractures. Fractures are very painful, okay? But fractures can also be life-threatening because remember, particularly in the long bones, the bones of the arm, and in particular the bones or the bone of the thigh, the femur, we have rather large blood vessels that go right along those. And it's definitely possible, as you can see with this particular x-ray here, that these are very sharp bone ends and they run the risk of causing damage either to the vasculature of the bone, resulting in potential bleeding, or nerve damage as well. Now, there are two bones in particular that we're really concerned about as far as being potential life-threatening fractures. What are those two bones? The what? The femur is one. Pelvis. Femur and pelvis. Your patient can die from either a femur or a pelvic fracture. If you get to choose which one of those two you get, take the femur fracture because you have a greater chance of survival. Literally, the patient can lose all blood volume from a pelvic fracture. And we'll talk more about pelvic fractures in a minute, but understand in almost all pelvic fractures, rarely is there going to be an all or a none in medicine, but in almost all, the pelvis is kind of like this. Weakest areas in the front, weakest areas in the back. When you have a pelvic fracture, Miriam, generally you're going to have a fracture in those two areas, and the pelvis is going to do this. That's called an open book pelvic fracture. Now, when you're assessing your patient and you're coming down and literally you're doing your hands-on assessment here, Aziz, if you feel that pelvis kind of move like this, and your patient screams out in pain, that's a pretty good indicator that we've got something major going on. Guys, once you've identified that, that's a type of crepitus. Same way with if you have unstable section of the skull, don't call your buddy over, even if he or she's in paramedic school, and say, hey, you got to feel this, okay? First of all, pelvic fracture, every time we do that, we're making our patient bleed more and we're causing unnecessary pain. If we're palpating unnecessarily the free-floating segment of the skull, every time we push on that, we're raising the intracranial pressure. And when we raise the intracranial pressure, we're wiping out brain cells. And so that's not good for your patient. Some of the things that you're going to see with fractures of any type are going to be, first of all, pain, all right? Second, we can have a decreased pedal pulse or a decreased distal pulse, or even an absent, not pedal, but distal pulse on the affected extremity or that particular area. Quite often you will see pallor. Aziz, what does the word pallor mean? It's okay. What's pallor mean? A gray color. And that's the key here. Pallor is not pale, okay? Pale is kind of, I was going to say not you, the color of your shirt. But actually your shirt is actually more the color of pallor of what you would normally see, okay? Pale is just kind of like a plain, that's pale right there, okay? That slide. just a plain kind of a pasty white color. Pallor has a combination of paleness and some cyanosis put in there together. With this, your patient can also have decreased range of motion or actually no motion as a result of either the structural defect. This guy's not going to be moving his leg or his arm. I'm sorry, not his leg. Because it's not going to work. But second of all, he or she's going to hold it in place because the pain is going to be so intense. They can have also a condition that's known as paresis, Paresis. Paresis just simply means weakness, being able to move it to a certain ability, but not enough. Now, the other things that we're going to be concerned about in here, Taki, are not only going to be vascular and nerve damage, but again, if you're looking at this, we can potentially cause permanent damage to the muscle as well. So as we're going through, we want it to be as gentle as we possibly can. Test question here, guys. Why do fractured ends cause bone loss? Say it again. Well, now remember, with traction, in reality, the only fracture we want to put traction on is the what? The femur. Okay. Okay. So So movement. So one of the things that we do with splinting is that it not only helps to reduce pain, but it also helps to reduce blood loss when we do a really good, adequate job of splinting our patient. Now, a couple things that's going to be important for you to remember when you're splinting, and this is true whether you're splinting a fractured arm, Martina, or if you're splinting the spine. We have a tendency to think of, oh, well, we're going to splint, that's going to be an arm or a leg. What we're doing here is when we put our patient on a long backboard, we're splinting the spine. That's exactly what we're doing. Number one, check PMS prior to and after we do the splinting, and periodically on the way into the hospital. By PMS, I'm talking about pulse, motor, sensation. If we have that present, Colin, and then we lose it after we splint. Let's say that we've got a nice, good, strong distal pulse, and then afterwards the patient's complaining of numbness, tingling. We go to check the radial pulse because we splinted this. There's no radial pulse there. Now what do? Don't remove it. You loosen the splint first, okay? You loosen the splint. Because remember, if we move the splint, especially if this is the kind of bone fracture that we're splinting, now we've got all that movement and we make a bad situation even worse. So we generally are going to go in and remove that. If we're splinting the spine, and by spine I should say the spinal column, because that's what we're actually splinting, if we lose PMS, now what do? Say it again. We're not going to take the patient off of it. We're going to note, just like you said, we're going to keep it there. We're going to note the change and make sure that we advise the hospital of that. That would rise to the level, I would tell you, Ryan, that you should make notification of that change in your radio report. Now remember, in your radio report, that report, regardless of how critical your patient is, it should be less than a minute long, okay? If you need to, you can make updates on the way in. But again, you got to allow the hospital to get ready for you, as well as you don't want to tie up the frequency for other units that are coming in. So you got to kind of pick and choose the information that you're going to share. In this situation, that would be definitely something that I would share with the hospital to make sure. Understand the difference between a closed and an open fracture. As we're looking at this one, would you say that that is a closed or an open fracture? And I'll tell you right up front, that's a trick question. Say it again. I heard somebody. Why not? Yeah, so we really can't see the skin. Now we can see the outline of the muscle, and we've got a little bit of something up here we're not entirely sure of. But again, we can't tell whether that bone has protruded. Here's the other thing. You don't have to see the bone, Martina, to classify it as an open fracture. Sometimes, particularly with fractures of the femur, there'll be a break, the bone will protrude through, and then because the muscles in the thigh are so strong, strongest muscles in the body, they will contract as a result of pain, and they'll pull that bone back in through the skin. That leads to a whole host of problems for our patient, both now as well as in the future. Number one, again, Landon, as we said, we got those bone ends that are moving around. Guess what? They're going to be doing some cutting, all right? So we're going to have some additional trauma. Second thing that happens, though, is that if we have a bone end that comes out, Bella, and then it retracts back in, now we have an infection problem. And ladies and gentlemen, infections of the bone are some of the most difficult to clear up, and they can indeed be life-threatening. Now, you and I are not going to be working in a sterile space, but what we need to do is we need to try to make the treatment of our patient as clean as we possibly can. Don't take the attitude of, well, I'll just let them treat infection at the hospital. Try to start the reduction of the infection process when you come into contact. Are you going to be able to eliminate that? Nope. In no way, shape, or form. Those of you that are already working in the field, Landon, I can imagine you've probably gone into some nasty houses, okay? And they're not nasty because they're in Estill County. They're nasty because they're occupied by humans, okay? I've been in some of the wealthiest homes in Georgia, and they were nasty. They were just nasty. So money does not make you clean. All right, so just kind of keep that in mind. So again, no doubt about this one as to whether it's an open or a closed fracture. All right, and so in this particular situation, we're looking at a pretty serious fracture of the femur. All right, now again, just like I said, there could be muscle loss, but here's the other thing: is that remember, what's not happening with this bone in its current shape? Say it again, Sydney. Blood flow. Excellent. That's just the answer I wanted to hear. So there's no blood flow. Remember, bone, even though it is very hard, it is very strong, it's still tissue. Just like any other tissue you have in your body, Martina, whether it's your skin, your heart, or your kidneys, all tissue requires an adequate blood flow. Failure of that blood flow results in hypoxia and cell death. Eventually, what's going to happen is if we're not able to take care of this patient and get them into a surgical center, primarily, this guy needs to go to a trauma center. There is a possibility that they can begin to lose bone. Types of fractures, hairline fractures, also commonly known as what we would call stress fractures. With hairline fractures, you notice there's no angulation of the bone that you see in here. Literally, it is a crack. Now, we can have either complete hairline fractures or we can have incomplete. Now, you and I are not going to know which is which because we don't have x-ray vision. With these particular types of fractures, your patient may actually be able to walk and to move. So again, a lot of people in the general public will say, "Oh, well, I can't have a fractured bone in their leg. They're able to walk on it." Well, trust me, it'll hurt, but this is the type of fracture that you'll see that your patients can walk on all day. There are impacted fractures, or also commonly known as comminuted fractures. So, looking at this x-ray, and I don't expect you to be a radiologist, what do you think happened to this person's hand, and in particular to their finger? What was the mechanism, Danny, do you think that happened that would have caused this type of fracture? Probably what? Not quite. Aziz? Nope. Yeah, a common thing that we call this type of fracture, and sometimes it can be a fracture, sometimes it can be a dislocation, sometimes it can be a sprain, is I know some of y'all probably played football, and so you probably got your fingers jammed. And so this is probably what happened in this situation. This person went to fall, and when you go to fall, your natural reaction is to do this, okay? Which again, remember, all of the impact of your body going to the ground, this is where it all begins. And so literally the impact, especially if the impact was on fingertip, can literally cause this type of fracture. Now, let me ask you a question. And remember, we've got this as a fracture of the hand, but this can be a fracture of any of the long bones of the body. Bella, what would be another situation where you might see an impacted or a comminuted fracture? Okay, your hands, or what else? What are you going to say it again? Your feet. Yeah. So let's say that you're in a burning building, and you're going to decide, am I going to die from smoke inhalation and fire, or am I going to jump out of the building? And I jump from the second or third floor window. If I land on my feet, then the narrowest part of the bone is going to be the weakest part. And literally what's going to happen is that you're going to get something like this. And it can potentially either have a kind of a transverse or a longitudinal fracture in here, or literally you could see multiple fractures in here of where the bone just crumbled, okay? We see a lot of comminuted fractures in elderly white Asian females because they're losing lots of calcium in their spinal column, as well as within their hips. And so just the action of walking can cause these types of fractures that will come into play. Transverse fractures are fractures that run all the way through. Now, what's the difference between a transverse fracture and a hairline fracture? Doesn't go all the way through, okay? A hairline fracture is typically only part of the outward tissue of the bone, but it doesn't go into the medullary cavity. Remember, inside the bone, particularly all bones, but in particular long bones, we have that opening in there of where we have marrow. And the primary purpose of marrow in the blood is to do, okay, I just gave you the answer. Primary purpose of marrow in the bone is to produce blood, all right? So with a transverse fracture, you're going to have a fracture that's going to go all the way in. Which one, hairline, transverse fracture, runs the greater risk for infection for our patient? Why, Devin? Okay, yeah, because this goes just like you said. It's literally a complete fracture, and it's allowing access to the vascular system, so that if it, for whatever reason, it now becomes a potential as far as of an open fracture, And generally, what you're not going to see a lot of these become open because they're going to have to become offset, but it's possible. Now it has direct access to the blood supply. Taki. I will tell you, you're like about 80% correct. Trust me, people that have hairline fractures, especially if it's caused by a stress fracture, which is most of the time the cause of hairline fractures, they're not going to ignore it. The reason being is that most hairline fractures occur on your feet, okay, in the bones of your feet. Unfortunately, we have to use our feet to ambulate, to move around. And so simply because it's not a complete fracture, two things happen with a hairline fracture, especially of the feet. Number one, lots of pain because we're walking all the time. Second thing that happens with a hairline fracture, even if your patient is healthy, has no history of calcium or magnesium loss, has no bone diseases whatsoever, it's going to take a longer for that to heal up, just simply because we still do have some movement every time that we're walking on that fracture. So yes, that's going to be the primary cause of that. We see more hairline fractures coming about as a result of a pathological injury, but not always. Good comment there. This type of injury here, or this type of fracture, is almost always going to be caused by a high force impact. Do you think that impact is going to be lateral or longitudinal? Why do you say lateral? So what would keep this from becoming displaced then if it's a lateral type of injury? Muscles. So yeah, it depends upon of the age of your patient. You will see this type of non-displaced fracture mostly in people younger than the age of 40. When we have this type of fracture here and we get older, especially once you get up into the geriatric years, then most definitely you run the risk of this becoming more displaced, because not only are you losing calcium and magnesium out of the bone, but older people lose a lot of protein as well. Protein is necessary for the building of healthy muscles. And so we have muscle loss in here that helps to keep that from being able to hold in place. An oblique fracture is any fracture at an angle. Now, this right here this is what I wished I had earlier. This is a comminuted fracture. This is, you're going to have multiple fractures going at different angles. And as you can tell in here, this is a fairly decent illustration of basically the bone just crumbling in on itself. Over here, we've got an oblique fracture, and this is going to be more of an angulation type of injury. The danger with an oblique fracture is going to be sharp bone points, especially if it's in the femur, and the femur now the thigh muscle begins to contract out of pain or potentially decreased oxygenation. It begins to spasm, and it can begin to move that. And every time that two sharp bone ends move, then we're going to run the risk of our patient having tissue damage. Basically what you've got now with this is you've got two spears in your leg that are moving around. As far as a spiral fracture, this is one that just kind of goes around it. You can have either a complete or an incomplete. In this, we're going to see this quite frequently in cases of child abuse. This would also, especially in this situation, if we saw this type of fracture, this would also lead into what's commonly known as a green stick fracture. Now look at this right here, the fracture coming into play here. What you would often see in this situation is that it would not necessarily go all the way through. And with these types of fractures, if you see them in child abuse, they're almost always going to be of the lower extremity. So again, if you respond to a situation of where you're having to deal with a case of child abuse and you've got the child complaining of lower arm injury, either from the fact, and you would have to try to get your history on your patient. Basically, the parent or the caregiver grabs and pulls or grabs and twists. This would be the potential of this type of fracture that you would see. With these, and you're going to see, again, more commonly down here in the lower arm than you would be up in the up the top. A fatigue or a stress fracture, that's kind of what we had talked about here, and it comes about as a result of pathophysiology that's coming into play, so I'm not going to spend a lot more time on that one. Some of the complications that you're going to see, in particular with long bone fractures and long bone in particular of the femur, is a fatty embolism. Okay? Now, when a patient has a pulmonary embolism, let's kind of go back and review that. What are some of the signs and symptoms that you would expect to see with a patient that has a PE? What would be generally your number one sign or symptom that would occur? You're close. Say it again, Martina. Nope. Sudden onset. Sudden onset. Remember, here's the pathophysiology of a PE. The artery in the lung, just fine. Everything's moving along. Then all of a sudden, we've got a cork in it. Okay? So your patient begins to complain of shortness of breath and chest pain on one side or the other. That's one of the differentiations that we would see with chest pain disease as it's coming from generally a cardiac condition as opposed to a PE. So you have a sudden onset of chest pain and difficulty breathing. Now, pulmonary embolism or pulmonary emboli from a fatty emboli is not frequent, but we see this in particular with femur fractures, hip fractures, and pelvic fractures. Why? You got to speak up. So we do have some additional fat in that area, in particular because of the long bone, but that's not the main reason. You have a fairly decent size, depending upon the size of the person, your femoral artery may be about the size of your little finger. Not quite. Think about what happens in the recovery process for these people. Docky? Mm-hmm. If you break a femur, you break a hip, you break a pelvis, typically you're going to be bedbound, especially if you're a geriatric patient for a long time. This is one of the reasons why, particularly with fractured hips, and you're going to see a lot more fractured hips than you will femurs or pelvises. This is why when they go in and they do surgery on a patient with a fractured hip, they get them out of bed about 6 hours after they wake them up from surgery and say, you gotta stand up. Why? Because we've got to increase circulation for that particular patient. Otherwise, not only do we run the risk of a fatty emboli, but we also run the risk of a thrombus. Now, what's the difference between an emboli and a thrombus? Mm-hmm. Martina, what did you say? Mm-mm. They're both stationary. They get into the pulmonary artery and they're stuck. okay, whether it's an emboli or a thrombus. Well, it does break off, but so can an emboli. Remember, an emboli can come about as a result of fat. We talked, I think, a little bit about the potential of your patient who has a delivery, potentially 6 weeks after the delivery, dying from an emboli coming from the amniotic fluid. The difference between an embolus and a thrombus is that thrombus is a blood clot. All right. And so this is the big reason why they get these patients up and moving around so very quickly after these major surgeries. It hurts. If you've ever seen a patient with going through physical therapy with a physical therapist, or as I like to call them, physical terrorists, literally, they're crying, but this is something that has to be done. Otherwise, your patient runs the risk of developing a thrombus more so than an emboli and having a PE. Here's the other thing with a PE, okay? And regardless of the cause, whether it's coming from a fatty emboli or coming from a thrombus, is that probably about half the times your first sign or symptom is going to be a sudden onset of cardiac arrest. And now remember, we talked about the PE cape in here, of particularly with your patients that are in an arrest from a pulmonary emboli or a thrombus, but mostly coming from a thrombus, is that from the nipple line up, they're purple. They are a purple color. I've never, ever resuscitated a patient with a PE just simply because it's in a large vessel of the pulmonary tree and we just can't get anything in there. The thing about a fatty emboli is that, look at me, I'm squishy, okay? Fat internally is semi-liquid and it's squishy as well. That means it is form-fitting, okay? So it can go in and it forms a very, very efficient occlusion within one of the pulmonary arteries. Things that we're going to look at for our patient, okay? When you have a skeletal injury, look at both the tissue as well as the bone aspect. So don't just focus in on the bone, but look at the tissue, because generally when you have an injury to one, you're going to have an injury of the other. Regardless of whether it is a fracture or a sprain or a dislocation, understand that we can have compression of the vasculature as well as the nerves that are near there. Your patient actually runs the risk of having more damage coming from a dislocation as far as vasculature and nerve damage than they do from a fracture, because the nerves and the vasculature run right along inside that joint, which is a joint, again, is any place where you have two bones that articulate, that come together, whether it's a fixed joint and they don't move or if it's a movable joint. Make sure, again, to check PMS before, after, and during transport into the hospital. Now, when we're looking at fractures, location, much like they say in real estate, location, 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 fractures, as far as where they're at, the location also has a bigger impact. If we have a fracture that is in or near the epiphysis, which is basically the ends of the bone, that's actually going to cause more instability than if you have a mid-shaft fracture. Why? Because you have muscles on either side of the fracture that can hold it into place. Here's the other concern that you have with fractures in pediatric patients when they are in the epiphysis. Going back to your anatomy lesson, what else? What important role does this area play for your pediatric patients? Say it again. Why is that important? Well, yeah, you need to grow. You're right. If we have a severe fracture in this area here, generally it's not going to have a negative impact on the future ability of that bone to grow. If we have an open fracture in this particular area here, now we run a high risk of that area getting infected, thus, just like you said, Bella, having a bad impact on the growth plate, leading to the possibility that our patient may walk with a limp because one leg will be shorter than the others. Now, a lot of times this can be offset with prosthetic shoes, and many times these patients are generally not going to have any problems. The other thing that can happen, and this straight out of the Middle Ages, literally what they will do is that they'll go in and break the bone and stretch it. Why would they do that? Yeah. So if we break the bone, and generally what they'll do is they'll break the bone while the child is still in the growth phase. Usually what they try to do in this situation is that they'll come in and do this surgery prior to adolescence. Because in adolescence, there is such rapid growth in every part of the human body. Well, you want to catch it when it's a little bit slower. But literally what they'll do is they'll fracture it, stretch it out a little bit, and then the bone will begin to form what are known as iron clast and iron blast. You don't need to remember those words. But basically, that's the healing process that takes place. Now, they're only going to stretch the bone a few centimeters, okay? So it's not going to go very much. But the thing that's going to come into play here is that it will begin to heal, and it'll be stronger than the original bone will be. The thing with this procedure is usually it has to be repeated multiple times as the child is growing until they get through adolescence. Once again, what does that have to do with you as a paramedic? If you suspect that it is in the epiphyseal plate up in here, either end of it, you want to be really careful. Which, ladies and gentlemen, brings me to a question about a treatment that you may provide for medical and trauma patients that you need to be aware of a high risk. What is that treatment? Hint, it involves the bone. Say it again. Yeah, IOs. So we want to be really, really careful. We're going to use IOs in all age patients, okay? But we're really going to see the use of IOs. And the initial use of IOs actually started with pediatric patients and infants, just simply because infants are terrible to try to get peripheral IVs on, okay? And so generally what we're looking at is most of the time if we need an IV on an infant, that kid is critical, Bella. And so we got to have that IV. So generally what we do is we just simply drill a bone. Try your best, Miriam, when you are assessing, and most of the time with kids, we're going to go down into the leg, but become familiar with staying away from the growth plate as going into what's known as a tibial plateau. You'll learn more about that a little bit later, and then we will really dig into that in 362 in the summer when you come in for your labs. So the thing that we're looking at as far as our assessment for a particular patient is that fractures are not usually life-threatening with a few exceptions. Femur, pelvis, those are. Generally what we're looking at here, and you do not need to be worried about these categories as far as being able to identify them, but in your mind you need to classify basically threaten to life and limb, threaten to limb, or non-threatening. Here's the other thing to keep in mind about fractures. Fractures can often be very distracting. They can often be very gross looking. They can be very, very scary looking. Don't let them distract you from what's going to kill your patient first. Okay? Now, let's go back a little bit in talking about the difference between a distracting injury and a distraction injury, because those are two very different things. What's the difference? First of all, let's define what is a distraction injury. We've already covered this in class. Hanging. Okay, a distraction injury is literally where the vertebrae are pulled apart, most of the time coming about as a result of hanging. Good, Martina. Excuse me, a distraction injury is going to be anything that makes you go, ooh, that looks nasty. Real simple description. I think I shared with you that down in Georgia, we would run patients with degloving injuries on a regular basis. And again, these were nasty looking injuries. At the same time, they amazed me because they were such great anatomy lessons that weren't on a cadaver, okay? Literally, because what happened is the skin itself is pulled off, and you can see the underside of the skin disease with all the structures of the skin out here, and then here you could see, most of the time they were hand, you could see the function and form and the anatomy and some of the physiology that was going on of the hand itself. Those are not life-threatening, okay? Now, they can be limb-threatening, especially working in a carpet factory where you've got carpet fibers in them, got oil in them, it's not a clean place, but it's not life-threatening. Don't let those type of injuries distract you from the fact that my patient's blood pressure is now 70/40. Trust me, that's not coming from a distracting type of injury. You got something else major going on. So again, maintain your focus on what you're going to do. So let me get through my notes here. All right, any patient that has any type of an orthopedic injury, the assessment goes the same way, head to toe, all right? When we get into pediatric emergencies, you'll learn that with pediatrics, we typically want to go toe to head, just simply because that helps us to keep the curiosity of the kid intact, and they don't start crying when you're up here palpating around their head. But for adults, we're still going to do our assessment in the same way, unless there is extenuating circumstances that's going to keep us from doing that. Take into consideration your mechanism of injury. Was this a restrained patient that potentially went down and under? Thinking about the types of injuries that you would see with those particular patients, most of the time, down and under injury patients are almost always going to be orthopedic. And by orthopedic, I mean musculoskeletal, all right? Muscles and skeleton. If you have a patient that has an up and over, quite often, and I would dare say most of the time, those patients are either going to be unrestrained or improperly restrained. And now that complicates everything even greater, because not only are we worried about the skeletal system of the chest, but we're also worried about the pulmonary system. We're worried about the cardiac system, as well as the potential for a head injury. Now, when you've got a patient that has a serious mechanism of injury, your index of suspicion should always remain high. Don't be afraid to over triage your patient. Now, Landon, what do I mean by over triaging your patient? Say it for me one more time. Yeah, you're exactly right. So your patient, you're looking at your patient, and because again, remember, you have a disadvantage that the hospital does have an advantage over, spell of that disadvantage is the hospital's got lots more people, they've got lots more choice, and they can literally go in and look at the inside of the patient. However, Martina, you've got an advantage that the hospital does not have. You were on the scene. You saw the aftermath of what happened. You may not have seen what happened, but you can look at the car. You can look at the inside of the car. And anytime that you're getting an assessment on your patient, okay, and I'm telling you this because you're going to have some questions on assessment on your exam. Always, always, always make sure that you're not just looking at what happened at the outside of the car, but look inside the car as well, because that can give you some really strong clues, disease, as to the potential for your patient's injuries. If you got a really severe mechanism of injury, but your patient seems to be fine, there is absolutely nothing wrong with over-triaging that patient. Your ability or your tendency to over-triage patients, particularly in orthopedic and musculoskeletal injuries, will begin to diminish the more experience that you get, okay? That's just a natural progression. So don't let anybody make you feel bad when you do that. When you've got a patient that has a musculoskeletal injuries, you got to lay hands on them, okay? You got to touch them, all right? And the things that we're looking for is instability, particularly from a fracture, crepitus, all right? And we say that you hear crepitus. I've never heard crepitus. I felt crepitus a lot. So you're going to feel it more than you're going to hear it. And again, understand that crepitus is much higher associated with fractures than with dislocations. Sounds like a good test question, by the way. Anyway, so understand the role of crepitus playing in there. The other thing we're going to look for here is for the potential of edema. Now, even a minor fracture or a minor musculoskeletal type of injury can turn into a big, big problem. We'll talk about compression syndrome in just a little bit, as far as identification and treatment of that particular type of injury that could look at your patient. Number one, at the very least, Danny, being limb threatening, but compression injuries can truly become life threatening for your patients. Again, we've kind of beat the drum on PMS, so I'm not going to spend on a whole lot of time there. I do want to stress, if you find crepitus, don't find it again in the same location. Okay, just palpate it, note it, and move on for your patient. In your focused assessment, now remember, we have a rapid head-to-toe assessment, and the purpose of that rapid head-to-toe assessment is what, ladies and gentlemen? Life-threatening injuries. That's all that it is there for. You have your primary assessment, and your primary assessment is there only to say what's going to kill my patient in the next couple of minutes. Then you have your rapid head-to-toe, Rihanna, and the rapid head-to-toe is what could kill my patient beyond the next few minutes. Then we're going to come back, and we're literally going to have a focused assessment. Now, this question is not often answered. What is a focused assessment? Because part of our problem is we pull out the National Registry, and thank goodness those things have gone away, and you're hopefully, they're still on track for your practical exam to disappear by mid-2023. So my money is on the fact that you all won't have to take one. But part of our problem has been we've had on the sheet, we had focus assessment of the chest, of the pelvis, of the extremities. But what is a focused assessment in the real world? Okay, good. So it is literally your chief complaint. We're not doing, if we get a patient that's got a fracture or a potential fracture of the femur, we're not going to do a focused assessment of the chest. That'd just be silly, okay? We've already done our rapid head-to-toe assessment, and we've already assessed to find out if there are any life-threatening things in the chest, because We've listened to breath sounds. We've listened to heart tones. We've looked for tracheal shift, which again, by the way, is a very, 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 very late sign, as well as we're looking for JVDs, which by the way is a very early sign. So there's no reason to go back and do a focused assessment on every body organ or every section of the body. If, like Colin said, if the patient's chief complaint, I got this bone sticking out of my leg, I don't think it's supposed to be doing that. We got to do a focused assessment on that of assessing pain, paresthesia, paralysis, loss of distal pulses, loss of sensation, loss of blood, the potential for our patient having compression syndrome from that. When you are doing your focused assessment, look at the range of motion. And we kind of touched on this a little bit earlier in the fact that range of motion is what a patient's body normally is able to do as far as movement. Range of motion basically should be, for your arm, should basically be about 180 degrees. Again, as you get older, you will find your range of motion for your arm will be less. Regardless of the age of the patient, ask the patient, can you move your arm? Yes. All right. Can you raise your arm up and then lower it? Normally, we would think for somebody of your age, you should be able to raise your arm up and down like this. But if the patient says, I can raise it this far and no farther, make a note of that. We don't repeat that. Again, that's part of your focused assessment that you're going to go through. The other things you don't want to do is don't force your patient to go farther than what they're able to do. Many times the assessment of pain begins with the patient's face. So when the patient begins to show signs of pain by grimacing, just tell them, stop right there, no farther, let's bring it back down, all right? Now, when we're looking, you want to assess and know the 6 P's of evaluation. Number 1, pain. Enough said about that. Pallor. We've already talked about that. Paralysis, okay, not being able to move it. Paresthesia, loss of sensation. Pressure, if they say it feels like it's swelling on the inside, then that needs to lead you to begin to think about the potential for compression syndrome. Pulses, okay, distal pulses, and then poikilothermia. Goofy word that just simply means loss of temperature, and that's an additional P. So basically just remember, if our extremity is cold, clammy, while the rest of the body is nice and warm, again, it's probably an indicator that we've got decreased circulation. And number 2, a good possibility that we could have our patient moves into compression syndrome. If you think your patient's got a fracture or a sprain or a dislocation, then as far as your diagnosis, that's exactly what it is. Treat it as such. If you think it's a fracture, splint it like it's a fracture. If you think it's a sprain or a dislocation, splint it like it's a sprain or a dislocation. Again, watch your patients, especially in situations of soft trauma as well as fracture for compartment syndrome, or let's say that for whatever reason you are with a wilderness rescue team. If you've got an extended amount of time and you're out in the backcountry and it's going to take a while to get your patient out, even if it's a minor injury, that can develop into to compartment syndrome. So, what do we do for them? Again, remember, fractures can bleed and they can bleed profusely. As we're looking at this, make sure that you splint early. It helps to reduce pain. It helps to reduce bleeding. Don't be stingy with pain management, okay? To be quite honest with you, when I started, we basically didn't have much in the way of pain management other than morphine. You guys have got a lot more tools in your box. So be familiar with what it is that you carry and use the appropriate tool in the appropriate amount for your patient, okay? And as you're going through here, if you find an open organ, dress it. Don't leave it open, even if you have to dress around that wound. Now, again, in open fractures, one of the things that we want to do is that, first of all, we don't want to purposely try to put that fracture back into the skin. But when you splint, and especially when you're dealing with fractured femurs, a side effect of a traction splint is that it will often pull the femur back into the leg. That's not your fault. That's just the way the body works. Prior to splinting it, though, take normal saline, not sterile water, normal saline, and cleanse the bone ends. Flush that area as well as you possibly can. And by flushing, what I mean is get you a 1,000 milliliter bag of normal saline, plug in your IV macro drip, your 15 or your 12 drops per cc, and then cut off the end of it so that you actually have more volume as well as more pressure, and then use that as kind of like a small hose to go through and to irrigate that particular area. Again, don't use sterile water just simply because sterile water is, number one, going to cause your patient a lot of pain. Another one that you could potentially use would be lactated ringers, okay? In essence, what we're looking at is we're looking for something that's close to the pH of the patient's body as much as we possibly can. When you're dressing the wound, dress it. Don't use athletic tape or athletic dressings, stretchy time, like an ACE bandage, to go around that and hold it in place. That can potentially lead into the greatest or a greater amount of pressure. Let your patient help to determine how they're going to be transported. Now, obviously, if you're running a high risk of the patient having some type of a spinal injury, that's kind of, to a large degree, already going to have been determined for you. But again, remember, we don't use spinal immobilization as much anymore as we use spinal motion restriction. We just want to reduce the amount of movement on our patients. So it is possible that you would put a collar on your patient and have them up in a sitting position with their head taped to the stretcher, no backboard involved, okay? That's perfectly acceptable, but let your patient help to determine how they are going to be the most comfortable. Watch for your patients, especially of the lower extremities, to spasm. Question. We know that benzos are, in addition to being really good as far as being sedatives, as far as being really good for calming patients down with psychiatric emergencies, they're also really good muscle relaxants. Would you administer a benzo to a patient that is having severe pain from a femur fracture? And you know I'm going to ask you why, so just be ready to tell me why you selected your answer. Why not? How would it interfere with the circulation? Okay. Now keep in mind the big thing that we have a concern about with benzos is not so much circulation, although there is some there. Respiration. Okay. Anybody else? Call it.
The old answer depends. Yes, if it really needs to be to immobilize them or get them to lower anxiety for other reasons that could be causing issues, but also no, because if you relax those muscles, they could bleed more.
Okay. Yeah, that's a really, really good point, because when those muscles are tense, what are they doing? They're putting pressure on the vasculature, so it's reducing the amount of blood loss. Now, understand, no one ever died from pain. Now, don't hear me say that and assume Bill said, we don't have to worry about treating pain. Come on, be compassionate. Treat pain. But understand, again, you got to treat what's going to kill your patient first. So if you've got a patient that has a spasm, that may in essence be a very good thing for our patient because it will help to reduce the amount of bleeding that our patient is going to suffer. The big thing though here is we want to minimize the movement of those bone ends. As far as splinting goes, real quickly, because I'm coming down to the end of my time here. Understand, if you have a fracture, we're going to splint the joint on either side of the fracture. If you've got a dislocation, we're going to splint the bone on either side of the fracture. All right, just kind of keep that in mind as you're going there. Okay. Again, we talked a little bit about realignment of dislocations. Generally, we're going to splint those as we find them, unless, that was a question, unless, no PMS. Again, in that particular situation, if you are going to realign, probably a benzo would be indicated in this situation more so than pain. Why? Because remember, if you've got a dislocation of the elbow, of the shoulder, those muscles will begin to tense up. And this is one of those times when that spasm is actually working against you. We don't have any blood loss. Now what is happening is that we have decreased circulation distal to the injury. Give your patient a benzo, give them maybe a little bit of ketamine if you'd like. We'll talk more about those drug dosages a little later. And now that will help to make it much easier for you to reduce that. You got one attempt to reduce it. Bella.
Say you fracture and you have a dislocation, you have to redo one of the
Ooh, okay. Yeah, and again, I think that's a really good question. It goes to the illustration I like to say is your patient has not read their textbook. So you can potentially have both. Again, when you are looking at this, you got to go with what is going to have the most severe outcome for your patient. Now, the challenge is going to be here, Bella. Let's say that we've got a patient that has a down and under mechanism of injury. They've gone down underneath the steering wheel. They have a fractured femur and they have a dislocated hip. What's going to happen if, and let's say that in that situation, you have no pedal pulse whatsoever. Let's make it really obvious. What are you going to do in that situation? What do you think, Danny? What are you going to do? Fractured femur, dislocated hip, no pedal pulse. That's the answer that I was hoping somebody would say, okay? Safely, but drive faster. You can't reduce that type of injury without the potential of making the fracture worse. So that's one of those situations of where it's kind of like, I'm not sure what to do, okay? And we want to do what's going to cause the least amount of damage. Ryan.
Would you be able to use a traction splint in that scenario?
Oh, that's an even better question. Now, we know we don't use traction splints on anything other than what? They didn't have to be compound. Femur. Well, femur. Okay, we don't even use traction splints on tib fib fractures. So Ryan asked a really good question here. You're going to put a traction splint on? I hope not, because if you do, you're probably going to need to give your patient so much pain medicine that now they're going to potentially go in respiratory arrest or distress at the least. So in that situation, you got to give your patient as comfortable as you can, rapid, safe transport to the hospital, and judicious use of pain management medication in that situation. That's definitely going to be a surgical issue for your patient that leads to both the threaten for the loss of both life, blood loss, and limb occlusion of blood supply distal to that. That's a really good question. Did that answer it for you? Okay. All right. When you are assessing your fracture, how could you use your pulse ox to help you assess the level and the efficiency of circulation? Say it again. Yeah. Remember, pulse ox does nothing more than reads the blood at the surface of the skin. We got a fracture, and it occludes off the blood supply. You know, obviously we're going to put our 99.9 times out of 100 we put our pulse ox on our patient's finger. The first time you put it on your patient's with a fractured femur or a fractured tib fib, and you put it on your patient's toe, you're going to have a great opportunity to, number one, have a teaching moment, which is always good, and number two, to kind of show off your knowledge of saying, oh, well, this is why I'm doing this. I'm assessing the patient's circulation. I'm not assessing pulse ox, I'm assessing the circulation. If you get a normal reading, that tells us that we probably have pretty good circulation going there. If you get a reduced reading, how would you know is that from a hypoxia problem or a circulatory problem? Skin color would be one. What would be another one? All right. So again, this is good. You're taking all of the information in, but the other thing is most of the time you're going to put your pulse ox on in the normal location, one of the fingers. If you got a 98% up here and you put it on your patient's big toe and you got a 70%, that's a circulation problem, not an oxygenation problem, okay? So as we're going through, don't be afraid to use cold packs. Do not. This is one of those few do nots, Muna. Don't use a hot pack. Why? It'll cause more swelling and more bleeding. So we actually exacerbate the problem. Cold packs are good. They help with the reduction of bleeding. They help with the reduction of inflammation. They help with a reduction of pain, all right? Pelvic fractures, real quick. As we're looking here, the big thing, and we've kind of already talked about this, it says you can lose 2 liters of blood or more. Trust me, you can lose a lot more blood from a pelvic fracture. The big key thing that we're going to do here is that we want to immobilize the pelvis as much as possible. Now, this is a wonderful device. I remember when they first came out, I thought they were the greatest invention known to man because prior to that, both for hip fractures and pelvic fractures, we basically had to make a diaper using a sheet. The problem with using a diaper to bring it around, pull it tight, and then put a knot in it is that it's not very effective and it is very painful. The benefit of utilizing a SAM splint or whatever variety that you've got out there is that you can measure the amount of pressure that you're utilizing and it does not diminish. It does not begin to stretch out as you're transporting on the way into the hospital. Keep in mind that anytime that you've got a pelvic fracture, we're also going to be concerned about lacerations or ruptures to the bladder. How would you know if you had a bladder rupture from a pelvic fracture? Say it again. Incontinent of urine and what? What else would you see? Not bowel. Blood. So if you've got a patient that is urinating and there is blood in their urine, Obviously, we want to find out, hey, have you ever had blood in your urine before? If a patient has a history of kidney infections, that's always going to be a problem. The big thing that we're going to do here is we want to make sure that we're watching for that, for the possibility of infection. Last thing, real quick, as we're closing this section out, compression syndrome. Compression syndrome basically can be a soft tissue injury that now begins to occlude the vasculature, the nervous pathway, and destroying individual cells. Now, let's pull in a little bit from our cardiology. What happens to the body when we have cell death from a cardiac perspective? Say it again? No, well, yeah, it can regenerate depending on where it is. Say it again? I'm not talking about the heart. Let's say that we've got somebody that falls and they hurt their thigh or their calf.
Acidosis.
And what else? That's one thing. A release of contents, yes, but what's the big thing that we're worried about? Potassium. Potassium, all right? So when we've got our patient with and I would tell you, because I got several questions on the exam about compartment syndrome. Number one, the treatment or the identification is going to be much like we would see with a fracture. Loss of sensation, loss of distal pulses. The thing that we want to do is that we want to, in particular, number one, we want to get fluid going to help to dilute the amount of potassium that is coming back to the heart so the concentration is not as high. And what drug can we give? Sodium bicarb. That will help to neutralize the potassium when it gets to the kidneys. All right. I'll see you guys this afternoon.